Sure. Hi, my name is Dr. Roach. I'm one of the vascular neurologists. So I'm a stroke doctor over at UVA. I did my training at Ohio State University. Then I was at Virginia Commonwealth University in Richmond. And now I'm over at UVA, and I as one of the stroke specialists here, and I'm happy to talk to you guys and provide some additional information about stroke and life after a stroke, more importantly. And I will be happy to start when I get the green light from the team.
Yeah, I mean, I think you can go ahead. People should be able to, come in as they go.
Okay, let me just share my screen. This may be a little tricky, but all right, let's see. Okay. And are you seeing it in the presentation mode? Yes. Okay, great. So, did I really have a stroke? And this is a question we often get from some of our patients who may have suffered a stroke and may not necessarily have a lot of deficits. And so, the objectives of this is to talk about strokes and TIAs, or as some people might hear them referred to as mini strokes, know what the stroke risk factors are, signs and symptoms of a stroke, management, and then some of the complications. So a little bit about stroke epidemiology. So stroke remains the leading cause of long-term disability in the United States. It kills about 140,000 Americans every year, and every 40 seconds, someone in the United States has a stroke. And it costs us as a society approximately $34 billion every year to help diagnose and manage someone who has suffered a stroke. Stroke is actually a medical emergency. The same way you think of a heart attack as a medical emergency, it is a medical emergency, except it does not involve the heart, but the primary organ that's affected is the brain. And every minute that a stroke is left untreated, 1.9 million brain cells die, 13.8 million connections within the brain is destroyed, and about 7 miles of brain tissue is damaged. Each time treatment is delayed, you lose about 3.6 years of normal aging. So that's why it's really important when you come to the hospital, we're concerned about a stroke. Everyone is I'm sorry, there goes my pager. Everyone works quickly to address the problem because it is in fact a true emergency. So what is a stroke? A stroke happens when there's an abrupt interruption in the blood supply to the brain that leads to damage to the brain tissue, causing someone to have neurological deficits that last more than 24 hours. So for whatever reason, the brain needs to see oxygenated blood, and that blood supply gets disrupted. And if the brain is not getting oxygen-rich blood, then the tissue starts getting damaged, and if not treated, it ultimately dies. So there are two different types of strokes. The first one is an ischemic stroke, and the second one is a hemorrhagic stroke. And an ischemic stroke, ischemia is it's a fancy word of saying that there's a blockage in place, and because there's a blockage, blood cannot move past that blockage. So all of the brain tissue after the blockage is actually at risk of being damaged. And in hemorrhagic stroke, instead of blocking the blood vessel going up to the brain, you actually rupture the blood vessel. So you start bleeding into the brain. Most of the strokes that we see are actually ischemic strokes. So that accounts for approximately 85%, and 15% are hemorrhagic strokes. When we see hemorrhagic strokes, our primary concern, we have two concerns that are sort of the forefront of our minds in patients who present with bleeding in the brain as their form of a stroke. A, do they have high blood pressure that's not well controlled? And B, do they have an aneurysm that ruptured? We've all heard of TIA or mini strokes. Patients often present and they say someone told me I had a small stroke or I just had a TIA. And what that really means, TIA stands for transient ischemic attack. And in patients who have a TIA, the blood flow to the brain is compromised, but the neurological symptoms that you develop don't last for more than 24 hours. It is actually a warning sign that you are at a higher risk of having a true stroke where the blood supply gets interrupted and your deficits are going to last greater than 24 hours. We actually have a tool called an ABCD2 score that we can use to help predict if you did in fact have a TIA, what are your chances of going on and having a true stroke where the deficits are longer lasting. And just to show you what that looks like, we take into consideration the person's age, blood pressure, what type of symptoms you had, how long it lasted, and whether or not you had diabetes. And you can actually put that into a calculator and it will tell you if you're at low, moderate, or high risk for having a stroke within the next two days up to 90 days. So this is a very useful tool for doctors to share with their patients so that we're all on the same page and understanding how important it is to manage our various medical conditions to reduce your chances of having a stroke. So let's talk about some of the stroke risk factors. Stroke risk factors can really be divided into two groups, modifiable and non-modifiable. Non-modifiable stroke risk factors are the risk factors that you really cannot change. It's kind of like the hand that you were dealt. So the age is a non-modifiable risk factor. The older you get, the higher your chances of having a stroke. Family history and genetics are risk factors. There's some people with genetic disorders where stroke is actually part and parcel of the disease. And so those things are out of the realm of your control. The things as stroke doctors that we are really concerned about are the modifiable risk factors, because we can actually give you medication and encourage lifestyle changes to help address these risk factors with the hopes that in the long run, we would actually lower your chances of having a stroke. So modifiable risk factors are hypertension or high blood pressure, diabetes, some people refer to it as sugar, atrial fibrillation or AFib, smoking, drug use, sleep apnea, and if you have cancer. So let's talk a little bit about high blood pressure or hypertension. So this is a very busy slide and I don't want you to memorize it. The take-home point of this slide is high blood pressure, your blood pressure is actually managed by multiple different organs, play a role in helping you maintain your blood pressure. Believe it or not, your heart's involved. Your lungs are involved, your heart, your kidney, liver, all of these, even a part of the brain that's in the pituitary gland, all of these organs are actually involved in maintaining your blood pressure. So it's not just heart and it's not just blood vessels, it's actually an entire orchestration of multiple organs at play. So here's what normal blood pressure, the top number or the systolic number, we like it less than 120, and the bottom number, the diastolic number, should be less than 80. If you're outside of that range, depending how far out you are from that range, you would require medication. Some people like to take the lifestyle approach. I'm going to change how I eat. I'm going to exercise more, and that's great. But there are some cases where even with those changes, your blood pressure does not get within normal range, and so you may need a medication to help with that. This picture shows you that there are lots and lots of options available for controlling hypertension. There are medications that work at the level of the brain and the brain stem. There are medications that work on the heart. There are medications that works on the blood vessels. There are medications that work on the kidneys. So the point of this is, if someone starts you on a medication for blood pressure, and for whatever reason you can't tolerate it very well, it makes me lightheaded, I feel really nauseous, I just don't feel good when I'm on this. Some people, medications, it causes them to have a dry cough. Some people are going to get leg swelling. So these medications do have side effects, but if you are experiencing side effects from your blood pressure medication, just call your doctor and let him or her know that the medication's causing problems. And there are alternatives. We have a lot of tools in our arsenal when it comes to managing blood pressure. So instead of stopping the medication and saying, I don't like this because it makes me feel terrible, let us know that you're having problems with it, and we can find a medication or a combination of medications that work. It's really important for in the case of high blood pressure, as well as diabetes, that you take your medication every day, even on the days you feel great. Some people say, well, you know what, I don't need my blood pressure medication today because I feel fine, and I can tell when my blood pressure is high because I have a headache, or I can tell when it's high because my vision gets a little blurry. The fact that you're having symptoms tells us that your blood pressure is so high that it's potentially causing damage to organs. And so take your blood pressure medications, your diabetes medications, just take all of your meds as prescribed. And if you feel that a medication is not needed, then let's have a discussion with your doctor to determine whether you should stay on it, or the reason that you think you don't need it anymore is because it's actually working and controlling that problem. Blood pressure is important to control because it can cause you to have a stroke, heart attack, heart failure, vision loss. You can damage your kidneys if your blood pressure is not well controlled. So it's really important to take your medications. Let's talk a little bit about diabetes. So glucose, or sugar, glucose is a type of sugar, is actually the fuel that all of our cells need to function. And insulin is the chemical that helps take the glucose out of the blood and drives it into the cells. Pancreas, it's a tiny organ that sits just in the middle of the upper part of your abdomen, just under your, what people will refer to as their breastplate or their sternum. And there are two types of diabetes. You can have type 1, and in that case, the patient does not make insulin whatsoever. In type 2, you make the insulin, but for some reason, you either don't make enough of it or you make it and your cells don't respond to it. So for a little visual, so this is what your pancreas looks like. It's a little fatty tissue that sits right in the abdominal area. And when you eat, here's your glucose from that sandwich that you ate. And what happens, the pancreas releases the insulin, it binds to a receptor, and that receptor causes a little gate to open on your cell, and the glucose can get into the cell, and your cell can now use the glucose for energy and to make essential proteins and keeps the body going. Patients who have type 1 diabetes, and these patients are typically younger patients because they're diagnosed usually during childhood, they don't make the insulin. So they can eat that sandwich, and there can be lots of fuel floating around in the body in the form of glucose, but there is no insulin to cause the little gate to open. In people who have type 2 diabetes, you make the insulin, but for some reason, the connection with the receptor does not work very well. You can be insulin resistant, or you're just not making enough of it. And because there is a problem between the insulin and the receptors, you cannot get the fuel into the cell. So it's not uncommon for people who are diabetic, after they eat a very heavy meal, they can still feel very hungry because their body feels that sensation that I'm not getting the fuel that I need. And it's not because you're not taking in food, it's the cells are not able to access it. So some of the symptoms of diabetes, you can get blurry vision. Some people get really tired, weight loss, excessive urination, excessive thirst. And if you have any of these symptoms, even though you may not necessarily carry the formal diagnosis of diabetes, it should be a conversation you should have with your doctor so that they can keep an eye on things. High cholesterol. So the body makes two types of cholesterol, LDL and HDL. The LDL is the quote unquote bad cholesterol. The HDL is the good. So it's important to have your cholesterol under good control so that your blood vessels aren't clogged with cholesterol deposits or plaques. Some of the signs and symptoms of a stroke. I know that the FAST acronym has been used a lot in the past, and they've recently updated it, and it's now BFAST, are some of the ways you can determine if someone's having a stroke. Because not everyone's stroke is going to be weakness. Some people can actually have sudden onset of balance problems. So I actually had a patient yesterday who came to the ED. He was at home watching TV, and when he stood up, he noticed that he didn't feel weak, but he just had a really hard time walking straight. He said he was walking and he felt like he was drunk. He had to hold on to the furniture and to the wall so that he didn't fall over. And he was in fact having a stroke. If you have a loss of vision or any sort of visual disturbance in your eyes, if your face is asymmetric or droopy on one side, so you can ask the person to smile or show me all your teeth, and if you notice that part of their face is drooping, that's concerning for a stroke. You can test their strength in their arms, ask them to lift their arm up, and if they have a hard time even picking it up, or they pick it up but they can't keep it up, that's also a sign that someone may be having a stroke. And then the last one is speech. If they have a hard time getting words out, or their words are slurred, they sound like they're intoxicated, and you know they weren't drinking, but it's just really slurred, difficult to understand. Or some people can actually get very confused where they know what they want to say, but they just can't get the words out. So any sort of speech disturbance, you should definitely be concerned about a stroke. And ultimately, all of this boils down to sort of the opening comment where time is brain. So you see any of these symptoms, you really want to bring that person straight to the hospital. Don't wait and see if it gets better, because the sooner you get them to us, the better, the more help and more options are available in terms of treatment. So when they get to the hospital, there are several steps, but I'll talk about two of them: the NIHSS, or the stroke scale, and then we'll briefly mention what types of pictures they take to look at this person's brain. So what's the stroke scale? The stroke scale is actually an abbreviated form of a neurologic exam that the physicians are able to do. And based on that exam, I can tell what part of the brain is most likely affected in this person's stroke. Part of the assessment involves showing pictures, asking them to read, asking them to name objects, to do simple commands. And if you've had a stroke, some of these pictures may look familiar to you, or if someone that you know has had a stroke, they would have gone through this assessment where we ask them to describe what's happening in the pictures. And it seems like a very simple test, but we actually get a lot of information from it and can really pinpoint what part of the brain is most likely involved. In terms of imaging, the first scan of the brain that we do is actually a non-contrast head CT. If you remembered, I said that there were two types of strokes. You could either block the blood vessel or you could rupture the blood vessel. And depending on what type of stroke you have, it looks very, very different on head CT. On this image here to the left, this person is blocking a blood vessel. And so this darker area is the part of the brain that's not getting that oxygen-rich blood because the blood vessel is blocked. The person on the right here, they've ruptured a blood vessel. So this bright white pattern that you see here is actually blood spilling into the brain. This test, or the CT scan, is very important because knowing what type of stroke you have is going to dictate how it's treated. This person over here on the left, I would actually like to keep their blood pressure elevated, because if there's a blockage, the body's natural response is to increase the blood pressure to try to push past the blockage and hopefully keep the tissue alive. So patients who are having strokes, when they come in, even if they don't carry the formal diagnosis of high blood pressure, their blood pressure is usually elevated, and that's a tip that they might in fact be having an infarct. Over here, this person's pouring blood into the brain. I don't want their blood pressure to be very high. I would actually like to bring their blood pressure down slowly, because the skull, which is what houses the brain, this is a fixed space. If I keep pouring blood into this, it's going to start squeezing on the brain structures and can cause a lot of damage. So the CT scan really helps us differentiate what type of stroke we're dealing with, because the treatment for these strokes are very different. Some people, family members often ask, why can't they get an MRI scan? It's a better picture. It is absolutely a better picture. I like to tell my patients that taking a CT scan is like taking a picture with a cell phone, and an MRI scan is like taking a picture with a fancy camera where you can change the tone and the colors and do sort of fancy tricks. The problem is a lot of institutions, do not have access to an MRI scan, and the MRI scan actually takes a lot longer. The CT scan, from start to finish, from the time the person shows up in the scanner to them having their brain scan and the images available for me to look at it, takes all about 5 minutes. An MRI scan takes about 30 minutes. And so because of that, I need, in the immediate setting, I need to get an answer quickly to know what type of stroke I'm dealing with. 30-minute wait is not the best, and so CT scans have been sort of the gold standard and go-to in brain imaging when someone presents with a stroke. Patients can sometimes get a CTA, and the A stands for angiogram, and it's just a fancy way of saying, in addition to looking at the actual brain, the CTA helps us look at the blood vessels. So you get injected with a contrast, and the contrast lights up the blood vessels. And if you look at this picture, so this is the back of the head, this is the front of the head. Those are their eyeballs right there. And this vessel and this vessel, there are two of the large blood vessels in the brain, and they call the middle cerebral arteries. You see this one's coursing out here, and it's filling out and branching out and filling up this part of the brain. This vessel over here, you see that it lights up, but then it stops. And there are these dark spots. And the reason you don't see all of these blood vessels here over here is because there's something blocking it. And that's most likely a clot or a plaque. And so this person's having a stroke. So this is the right side of the brain. The images are flipped on CT scan. So the right side of the brain is not getting that oxygen-rich blood. And so they're having an ischemic stroke. They're blocking the blood vessel. They can't fill it out here. And so this will be someone that can either get TPA or that clot buster, or we can potentially talk to our colleagues in neurosurgery, and they can take a small catheter, go through the thigh up into the brain, and try to retrieve that clot. So the CTA helps us determine if we can find the blockage. The MRI, you do get an MRI later on because it does give us a little bit much more of a detailed look at how the size of the stroke. The MRI can give us different types of pictures, and for the purposes of a stroke, we look at something called the DWI sequence and the ADC sequence. A good way of remembering what to expect: the W in the DWI, the stroke will show up white, so W for white, and in the ADC sequence, the D for dark, the stroke shows up dark. So if I see someone and their DWI sequence has a bright white area, and in that same territory of the brain, there's a dark area, then I know that that's the area of the stroke, and it helps me determine what size the stroke is. There's something called a heme sequence. It just helps us know if, in addition to the ischemia, or if they blocked the blood vessel and the tissue got damaged, sometimes there could be a little bit of bleeding in there. The heme sequence will tell us if there are any blood products present. So how do we manage strokes? If you remember, I talked about all of the things that we can modify and things that we really have no control over. So I can't make you any younger. I can't change your race, and I can't change your genetics. So we can't change the hand that you're dealt, but we can address some of the conditions that would increase your chances of having a stroke. And that brings us to this slide. So if you have high blood pressure, we want your blood pressure to be well controlled, and the goals are blood pressure less than 130/90. If you have diabetes, we want your A1C, which is a 3-month average of what your glucose levels are, to be less than 6.5. Remember, we have good cholesterol and bad cholesterol. So the bad cholesterol is our LDL, and we want that to be less than 70. And if it's not, we can give you a medication called a statin. Statins for some people can cause some muscle pain. So we try to start you on a low dose, hoping that it would work. But it's not uncommon that some people may experience some muscle pain at higher doses. And again, if you do, just let your physician know, and they can make adjustments to it. They may switch you out to a different medication, but don't just stop taking it, because all of these stroke risk factors, we want to make sure that they're well controlled, because if you have any one or combination of these, then you're at a higher risk of stroke. So if we can control it, we want to really do our best to get a good handle on things and make sure things are well controlled, so we reduce our chances of having a stroke. Atrial fibrillation, if you do, we can put you on a blood thinner. Some people are on warfarin. There are newer agents available where you don't have to test your blood regularly. If you do smoke, we do encourage smoking cessation. And then we do aspirin, 81. And you may be on aspirin. If you're on a blood thinner, then you don't need the aspirin unless your cardiologist says so or another provider says so. But that's sort of in terms of medications, that's sort of the medication regimen you're looking at. The other huge component to recovery from a stroke is therapy. It is really, really important that you be evaluated by a therapist. Physical, occupational, and speech therapy should see you at the time of an infarct, and they're going to recommend how intensive your therapy needs to be after you've had a stroke. You really want to start exercising. You really want to start getting those brain connections that were damaged reestablished. And it's really important to work with a therapist. They can actually determine subtle problems that you may have that as a physician, I may not necessarily be aware of. So we really depend heavily on our therapy colleagues to see these patients, to provide recommendations. It's not uncommon when patients get admitted to the hospital, they say, well, doctor, I didn't eat anything all day. You know, I'm really hungry and I would really like a meal. But if the speech therapist saw them and they recommend that it's not safe for them to take in anything by mouth, then as much as I would like to appease and feed them, we really need to do what's in their best interest. And so there are lots of subtleties that they can pick up on, and they not only find the problem, but they can give you ways on and exercises on and things that you can do to get better and get back as much function as you possibly can to before you've had the stroke. Just some complications of stroke that people may not necessarily be aware of. Spasticity, so people get very stiff, they get a lot of cramping, a lot of pain. Again, if you're having these issues, let your physician know, and we can get you medication and exercises to help with that. Seizures, cardiac arrhythmias, so some people will come in with a stroke and then be diagnosed with atrial fibrillation. 40% of our patients who suffered a stroke suffer from depression after. A stroke is a really life-altering experience. You can go from a very high-functioning person to now needing the help of others to help with daily activities or even more complex tasks. And that can be quite distressing to some patients, understandably so, because there is a sense that I'm not as independent as I used to be. I now need someone to help me go to the bank, to remember to pay certain things. And with time, we hope that that improves, but depression is a huge problem. And if you are struggling with it, reach out to your primary care doctor. Reach out if you have a therapist that you see. It's important to tap in to let your friends and family know exactly what you're feeling with, because the last thing that we want is for you to suffer alone. There is no need for you to suffer in silence, but it's really important to let us know so that we can get you connected to the right resources. Some people develop migraines, and some people develop something called PBA or pseudobulbar or affect. And that's where they cry or they laugh inappropriately for no reason at all. And it can be, some people are aware of it, and it can be quite distressing to them because they will go out in public and they might just be at a restaurant ordering pizza and for no reason will just start crying. Again, there are medications, there are therapies out there, and we as healthcare providers are here to help you. We just need you to tell us what's going on and really develop that relationship with your doctor where you can share what's happening, so that even if they're not the person with the tools to help you, they can find you someone to provide the help. Here at UVA, we do have a stroke support team. They meet once a month, every third Wednesday in the month. It's led by one of our nurses, Abby. She's actually on the meeting today, and we'll love to have you join us. It's from 4 to 5 p.m. You can meet other people who've also suffered a stroke, hear their experiences, get tips on sort of navigating life after a stroke.
Yes, thanks, Dr. Roach. We'd love to have anyone and everyone come. It's kind of an open forum, good little meet and greet virtual. So thanks, Dr. Roach.
Yeah. And I think I'm going to pass this on to the therapist, and they're going to.
Thank you so much. That was really great, Dr. Roach. So now what I'm going to do is I'm going to pass it over to Ashleigh, and she's going to talk a little bit about the outpatient physical therapy aspect of stroke recovery. So let me get that pulled up for you.
All right, hi everybody. I am Ashleigh Dressel. I'm a physical therapist with physical therapy at ACAC. I have a doctorate in physical therapy that I got from Temple University up in Pennsylvania. And as Angela said, I'm just going to touch more so on the physical therapy side. So after you've had a stroke, how physical therapy can help. So the main goals, as Dr. Roach touched on, were really to help you return to your prior level of function. So that's in regards to just activities of daily living, so such as, getting dressed, getting in and out of your car, getting a meal prepped, things of that nature, as well as getting you back to work if you're still working. community outings, so being able to go out and enjoy the weather, being able to go out on hikes, hanging out with your friends, going to a restaurant, and then also trying to get back to a fitness and recreational activities as well. So the main component that we think about when it comes to the therapy side of things is this idea of neuroplasticity. So that is the ability of the neural networks in the brain to change and grow and reorganize after a stroke has occurred. So as stated, stroke recovery and the rehab side of it really relies on the ability of the brain to be able to heal itself through this idea of neuroplasticity. So when after a stroke has occurred and we start really working on exercises and movements, what happens is the brain cells start to regenerate and they start to reestablish and kind of rearrange their connections throughout the brain in response to the damage that was inflicted by the stroke. So essentially the brain works around those dead cells, as Dr. Roach kind of showed you guys in the pictures, and attempts to create other pathways in order to compensate for those changes. And stroke rehab is specifically kind of designed to really help spark these neuroplastic changes. So they've actually found with research that the brain temporarily increases its neuroplasticity in response to traumatic damage, which is why it's so important to begin the rehab process pretty much as soon as possible after the stroke occurs, as Dr. Roach touched on as well. So as soon as they pretty much get you stabilized in the hospital, the therapy team will come in and get you kind of on the road to recovery. So the brain and the central nervous system can really identify the damage that has occurred, but they need help to be able to change and they need help to be able to adapt. And the best way to provide this help and to stimulate the brain and activate that changing, that neuroplastic response is through exercise and repetitive motion, and especially heavy repetition of certain movements and activities will help retrain the brain. Initially, when you're in the hospital, depending on, the impact of the stroke and your function at that time, a lot of what they'll work on is consistent transferring, standing, walking, relearning those things if necessary. And over time, the consistent and repetitive efforts will help construct those neural connections and get you back to where you were prior to the stroke. So what's involved in stroke rehab? Definitely different from every single patient. Everybody is affected differently by their stroke, has different physical and cognitive outcomes. So it's not a cookie cutter approach. It's very individualized. And it's dependent upon multiple factors: the timeline, as we've touched on, the size and location of the stroke, how quickly your care was received, including, the speech therapy, the occupational therapy, the physical therapy, as well as other health conditions, so your comorbidities and your health habits. And when should it begin? As we've touched on, time is super important. The sooner you can start, the better you're going to be, and the more likely you'll be able to get that neuroplastic changes going and regain some of those lost abilities. So it's common for rehab to start once you are in that hospital, once you're an inpatient. As we said, once you've really been stabilized, that therapy team will start to come in and work with your care team. And then before being discharged from the hospital, your care team will work with you and your family to determine kind of the best rehab setting based on your needs, your home setup, and the severity of your ongoing impairments at that time. So some of the options include an inpatient rehabilitation unit typically housed within the hospital, a skilled nursing facility, some home health and home-based programs, and then where we kind of come in is the outpatient clinic. So how long does therapy last? It really, once again, it's very dependent from person to person. Some people recover quite quickly and may not even need to take all those different steps in rehab, while others may need long-term rehabilitation. So it's just dependent upon the person. And in general, successful stroke rehab depends on a couple factors. So there's the physical factors, such as the severity of the stroke, like we said, in both the physical and the cognitive effects. The emotional factors, such as motivation and mood, as Dr. Roach touched on. A lot of individuals after a stroke have some difficulty with depression and motivation, and also the ability to really maintain compliance and maintain that work with the rehabilitation activities and the exercises provided, and keeping up with that outside of therapy. And also social factors, so really support from friends and family, your work environment, your home environment, all of that can play into kind of the long-term or short-term success of your therapy. So speaking more from our realm here with physical therapy at ACAC is the outpatient physical therapy. So how it works is you would need a prescription from your provider, whether it's the provider in the hospital, such as Dr. Roach, or if you're to the steps where your primary care physician is kind of managing you from there, we just need a prescription. And on day one, your physical therapist will perform a very thorough examination, assessing your mobility, your strength, your balance, flexibility, your stamina, or your kind of aerobic capacity, as well as if there's any ongoing, more so kind of neurological deficits. And based off of that thorough examination, as well as thinking about your past medical history and other personal factors such as other comorbidities, your household environment, things of that nature, your PT is going to work with you to come up with personalized goals to help you achieve the highest possible quality of life. And as we said, really try to get you back to who you were before the stroke occurred. And your rehab plan is not going to be a flat line. It's going to be changing. It's going to be evolving during your recovery as you progress and as your needs change. So some of the things that we might work on exercise-wise, physical activity-wise, based on your presentation are some motor skill exercises. So really helping to improve not only your muscular strength, but your ability to coordinate movement patterns. So abilities to reach across your body to grab that cup up in a shelf, your ability to turn and look over your shoulder, as well as generalized strength training for, your arms, your back, your core, your legs, some functional mobility training to just help you improve your overall kind of quality of those movement patterns. So working on walking, working on transferring, getting up and down out of a chair, getting up and down off of the ground. We can also work on utilizing mobility aids. So if you need a walker or you need a cane afterwards, being able to really become competent with the use of those, but then also hopefully with time, as your strength and balance improve, being able to wean you off of higher level aids such as a walker, possibly down to a cane, and possibly down to nothing based on your progress. We can also work on exercises targeting range of motion and flexibility, especially if somebody's presenting with some spasticity after the stroke. There's also this cool treatment that's called constraint-induced therapy. So say if somebody has had a stroke and they have effects in their right arm. So what we would do is we would actually restrain the left arm that's probably been helping out a lot and taking over for a lot of these tasks, and then really make you utilize and practice with that affected limb to improve its overall function. And we can also work on balance training, as well as just getting you back cardiovascular-wise, working on aerobic training. And I forgot to mention in this slide, but we also have aquatic therapy, which is really great. Say if somebody has spasticity, or say they have balance issues and it's hard to work on the land-based therapy, we can get them into the pool with one of our providers in that kind of supported environment with diminished weight bearing that can actually really improve someone's ability to move and to improve their gait dynamics and improve their strength in a more comfortable and safe environment. So today I'm just briefly going to run through a couple exercises specifically targeting posture and some leg strength that are appropriate for more so prevention pre-stroke, or even for people that have had a stroke and just want some easy exercises that are relatively safe to do at home. However, I do ask that you rely on your own intelligence and your knowledge of your health history and your comorbidities whenever you're starting a new activity to decide, if these exercises are safe and if they're appropriate for you. If you're not sure about that, I would definitely suggest you speak to one of the members of your healthcare team before beginning any kind of exercise program. So just give me a second. I'm gonna kind of spin around and I'm gonna go out in a chair in front of us, and I'm gonna walk you guys through just a couple basic exercises. All right. I hope everybody can still hear me and see me here. Pretty much everything we're gonna do here is gonna be based in a chair. So you wanna have obviously a nice stable chair. We don't want anything wobbling around on you. You wanna be in a good open environment so you're not at risk of possibly kicking something. Back up a little bit. All right, give me 1 second, guys. And the first things we're gonna work on are a couple posture exercises. So the first one we're gonna do, these are called chin tucks. And I'm briefly just gonna take my mask off so you guys can see what I'm talking about here. So the exercise is essentially doing like a chicken neck. So what you'll do is you'll think about bringing your chin kind of back into your neck. You're retracting that chin. That's gonna work on the muscles in the front of the neck, which can help with kind of an upright head posture. It can help you being able to scan your environment when you're walking and when you're moving so that it keeps you safer, especially if you're having some balance difficulties. So let me just show you from the front one more time. So we're just retracting that chin posteriorly, thinking about making a double chin there. So what I would recommend is start like 2 to 8 repetition, or I'm sorry, 2 sets of like 8 to 12 repetitions or so, whatever really feels appropriate for you. Our next one is what's called a scapular retraction. So that's basically just a little shoulder blade pinch. So I'll show you guys that from a couple different directions. So the first direction I'll show you from the side. As you can see, even I've got some bad posture there with my shoulders rounded forward, which as we touched on with your balance and with your scanning of the environment, if we're really rounded forward, that's gonna put you at a little bit of a disadvantage and kind of decrease your safety and your capacity when you're up and moving. So you're gonna think about trying to pinch those shoulders down and back, like you're trying to pinch your shoulders towards your opposite back pockets. And as you can see, it kind of brings those shoulders back and brings you up a little bit taller. So I'll show you that from a backwards view here. So if you can see, I'm thinking about my shoulder blades down and back. And once again, I would do 2 to 3 sets of 8 to 12 with those. What feels comfortable, what gives you a good workout. And our final one for our posture is literally just a seated posture hold. So you'll come kind of towards the edge of your chair so you're not supported against your chair. You want to think about both feet flat on the floor. And then you want to think about sitting up nice and tall. You pretty much want everything in a nice straight line from your hip to your shoulder to your ear. So you might have to do a little chin tuck. You might have to do a little shoulder blade squeeze to get you in that nice upright posture. And then we're just gonna sit and we're gonna hold that posture. Initially, if you can only hold it for 10 seconds or so, that's okay, relax out of it. And then go back in it. And then try to build up your holds, build up your tolerance over time. So start with, a 10-second hold for 5 to 10 repetitions, building up to a 20-second hold, building up to a 30-second hold. And do that kind of throughout your day. If you're doing your dishes and you really notice you're rounded forward, try to work on that posture a little bit. Now our next exercises we're gonna run through here are just a couple seated exercises, again, for the legs this time. So can you tilt it down a little bit?
Yeah.
So this one are just gonna be some seated marches. They're gonna work on those muscles in the front of your hip called your hip flexors that are really important for normalized walking mechanics, stair negotiation, curb negotiation, all that good stuff. So you're gonna sit forward in your chair, sitting up nice and tall again, and we're literally just marching, bringing those knees up as high as you comfortably can without really trying to throw yourself backwards. You wanna maintain good posture while you do that, kind of alternating back and forth. And with all of these leg exercises, just like your chin tucks and the shoulder blade pinches, I would say start at around 2 to 3 sets of like 8 to 12 per your tolerance. Our next one is called a long arc quad, and that's going to work those thigh muscles, those quads. Super important for, once again, walking, getting up and down out of a chair, stairs. So what you're going to do is you're just going to kind of kick that leg out, hold it for a second or two at the top if you're able, and then slowly control it back down, all the way back to that initial starting position. So nice and controlled, little squeeze at the top of that thigh, control it back down. And then our next one is a heel raise. So I'm just gonna tilt this a little bit more so you guys can see my feet. So you're gonna be seated, feet flat on the floor, and then we're just raising up. You should feel this in those calves. Very important to have that calf strength for walking dynamics, for stairs. So we're just going slow and controlled, little pause at the top, control back down. And then we're actually gonna do the opposite. So we're gonna lift our toes up this time. That's gonna work on the front of that shin and that ankle. So that way we can make sure those toes are getting good clearance when we're walking. And hopefully we're not tripping and we're not catching those toes, leading to a fall. And then our final one is going to be just a sit to stand transfer. So a really good functional strengthening exercise. Actually, hold on, let me tip that back down a little bit. What we're gonna do, once again, nice sturdy chair. It's probably a good idea to put your chair back against a surface that isn't gonna move or slip, so up against the back of your wall or on a heavy piece of furniture so that we're not risking that chair sliding out from under us. What you'll do is you're gonna scoot forward to the edge of the chair. A lot of people make the mistake where they have their hips really far back. And what that does is that puts you in really bad alignment for your legs to be able to do their job. So you're gonna fall backwards every time. Gravity is gonna win. So you wanna scoot forward. You wanna have your feet planted. You wanna have your feet about shoulder width apart. And you want your foot and ankle pretty much kind of underneath of you right there. And then what you'll do, you're really gonna think about driving through those heels and pushing through those legs to stand up nice and tall. Now, if you're not able to do that without using your hands, that's fine. You can use your hands to help. Or you can have somebody there to kind of guard you and maybe give you a little assistance initially. You want to keep it safe, but ideally you want the legs doing the work and not just your arms pushing you up. All right.
Okay, so I see that we've had a few questions in the chat. And I think Dr. Roach said, I think there are a couple for you. If you wanted to go ahead and answer those.
Sure. I did mention cancer as one of the modifiable risk factors, and someone had a question about that. That actually works in sort of 2 ways. There are people who have a diagnosis of cancer, and they may not necessarily have the traditional stroke risk factors. So they may not have hypertension or diabetes or high cholesterol, but they, let's say, have lung cancer. Cancer puts the body in what we call a hypercoagulable state. So it makes it really easy for you to form clots. These tiny clots that you form can then travel up to the brain and get stuck in one of the blood vessels in the brain, and so they can have strokes. So cancer patients, just by having cancer, are at a higher risk of having strokes. And so oftentimes these patients come to us and the question is, well, do I need to be on a blood thinner since my body is prone to forming these clots? And that's a discussion that we have with them on a case-by-case basis. Cancer also works in the opposite direction. Believe it or not, some people their presenting symptom for their cancer is their stroke. So I've had a gentleman come in with a stroke, and lo and behold, when we were doing the scan for his head, usually they get a little part of the chest because we do the CT of the head and neck. And there was a little mass sitting in his lungs, and he was diagnosed with cancer because of his presentation with the stroke. 2 months later, he went in, they did the surgery that took the cancer out, and he's doing better. So the stroke was really the thing that tipped his team off that he did in fact have an undiagnosed malignancy or cancer. So it goes both ways. The stroke can help us point to the cancer, and some lung cancers, actually, the body makes these tiny antibodies that affects the brain, and we can figure out that someone has a cancer maybe 2 or 3 years before the actual mass shows up in the body. So it's quite fascinating how subtle changes to the brain can really clue us into what might be happening in another part of the body, because the brain is just so sensitive to changes. So you can either have cancer and be at an increased risk for having a stroke, and then there are some types of cancers, breast, lung, melanoma, they like going to the brain, and then there are sometimes people will have a stroke, and in our workup for that stroke, we will find out that they have cancer.
Okay. It does look like she asked if you are talking about lung cancer or about breast cancer.
We see it all. You can have lung. So the common ones that go to the brain or tend to affect the brain, lung, breast, melanoma is a very common one. There are people who, melanoma is a very interesting form of malignancy, because you can be treated with melanoma in your 30s, have it resected, and be completely in remission until you're 70 years old and it resurfaces. And some people, some uterine or ovarian cancer, you can make these antibodies that I talked about that do show up in the fluid that bathes the brain. And when we check the fluid, we can see that it's actually present there.
Okay. We did have one person ask kind of before the presentation about aspirin, whether or not it was fact or fiction. You did touch on that. So I'm not certain if, Joy, if you need any further answers, or if you feel that that was sufficient, you could certainly just message us. And yes, we'll send these exercises to Abigail, so that if anybody needs them, we can certainly print them out and send to you. Do we have any other questions?
I think some.
Yeah, so it's recommended to take a baby aspirin every day, ?
Yes, so for stroke patients, we do give aspirin every day. Some people are worried that it's a blood thinner and I'm gonna bleed. Aspirin in the eyes of a vascular neurologist or a stroke doctor, it's not a true blood thinner. It works on the platelets, which is part of the blood. And so we do recommend taking an aspirin. You can take 81 milligrams every day. Studies have shown there is no difference between the 81 and the 325. So 81 is just fine. And depending on whether or not you have that abnormal heart rhythm that we talked about, AFib, some people have atrial fibrillation and they can tell that their heart's kind of fluttering really fast. Some people go into AFib and have no idea that they're going into AFib. If you are seen here at UVA and you come in with signs and symptoms of a stroke, based on what your stroke looks like, we may send you home with a heart monitor. And that heart monitor gives us a lot of information. It can tell us if your heart goes into that atrial fibrillation, and if it does, then the aspirin is really not very good at thinning the blood. We may put you on a stronger medication. So some of you, or you may know someone who's on apixaban or Eliquis. That's because we really want to make sure that the blood is thinned enough reducing the chances of another stroke. But the heart monitor also gives us important information that you may not be aware of. So I sent a lady, she came to see me in clinic. She had seen many neurologists. She had these strokes. And I said, I'm going to send you with a heart monitor. And she says, well, why are you sending me with that? I've worn those things and never tell us anything. I said, well, let's do it for 30 days. Let's just make sure everything's okay. 3 days later, she's at home doing laundry. 3 fire trucks and an ambulance show up outside. And what happened was the heart monitor detected that her heart was stopping for seconds at a time. 13, 14 seconds, she would have these pauses where her heart wasn't beating. And they were worried that she had passed out at home. So the ambulance showed up, the squad came. They thought she came for her husband, funny enough, because she showed up at the door with a basket of laundry. And they said, no, it's actually you we're here for. And she said, well, what's going on? And they said, your heart's stopping. And she said, well, I feel fine. And they're like, no, your heart's stopping. And so that day she was taken to the hospital. 2 hours later, she had a pacemaker placed. So she didn't go into AFib, but we did find other cardiac abnormalities. And so she got a pacemaker and if that wasn't done, she could have potentially died during sleep or doing things, because you don't always feel symptoms from when things are going awry until it's too late. So a stroke workup is quite revealing. We don't just figure out what's wrong with the brain. We often get clues about other parts of the body.
You want to take this?
Yeah, I'll take this one. So Catherine asked if a person has had a mild stroke a couple months ago with no really big visible effects, would PT still kind of be appropriate to help not only kind of reduce some anxiety about the possibility of another stroke, but also to work on balance and things of that nature that might be kind of diminished since the time of the stroke? And Catherine, the answer is yes, for sure. Not only, will we assess her to see if maybe there are some of those nuanced changes, such as balance or strength deficits or mobility deficits that she might not even notice herself, she or he, might not even notice herself or himself, that we could possibly pick up on. We'll also, assess vital signs to see if that might be an issue as well. So we can address those possible deficits that we might find, but also be more preventative in nature too, just by optimizing kind of that cardiovascular output, the heart and the lungs, and also maximizing strength and balance to keep you safer as well afterwards.
So it looks like Joyce asked, does a history of DVTs make a person more likely to have ischemic stroke?
That's a great question. We do, especially if we have a young person coming in with a stroke, it's, well, why are you 34 with a stroke? That's unusual. I think if you do have a history of DVTs, we may actually send you to see a hematologist or a blood doctor. We will do the initial workup, because our question is, why is your body forming clots? And we are more particularly worried about people who get DVTs, especially younger people who get DVTs. And part of the stroke workup is an ultrasound of the heart. Some people, when you're in your mother's womb, there's a small hole that connects the left side of your heart to the right side of your heart. Because you're in your mom's belly, you don't need to worry about breathing. She's doing all of the work. But when you come out, that hole, that connection needs to close. And if that connection doesn't close, if you have a DVT in your leg, piece of that clot can actually come up, travel up to the heart, and it crosses through the connection and it goes to the brain and causes you to have a stroke. So people with DVTs or PEs, it is very part of your stroke workup would be looking to see if you have some sort of underlying condition that has been missed where you are prone to form clots, because then if that's the case, you may need to be on a blood thinner. So particularly women, if we see women that come to us and they've had multiple miscarriages, they've had DVTs, PEs, they're young, we do look into, is there something else going on that has not been addressed that's now presenting as a stroke? And as I said before, with the cancer and with the people with the heart blocks, sometimes the stroke is the thing that gets you to the hospital. But when we get here, then we find out that there might be other things in other parts of the body going on that needs to be addressed. So if you do have a DVT or a PE, we will do the baseline sort of blood work. And if that is abnormal, we may refer you to see a blood specialist or hematologist.
So Laura asked, at what point after the second vaccination is it safe to do PT or workout in an indoor setting? So based off of what the research shows, it seems like about 2 weeks after your second vaccination is when you're pretty much inoculated, but that doesn't mean we should stop taking precautions and wearing our masks and using all of the things that the CDC has told us to do, such as the distancing, hand washing, all of that. Here at ACAC, PT at ACAC, we have the entire time been following CDC guidelines on all of those different things, spacing, cleanliness, and wearing masks. So even prior to having the vaccination, we are maintaining a very safe environment, as safe as we can within our clinics. If that is a concern, we also have private treatment rooms, if that would be an option, if you're really concerned about the safety of the environment. Working out in an indoor setting, I think that's just using your best judgment and still, as I touched on, maintaining those kind of safe distancing and cleanliness practices. At ACAC, I know they're doing their best to keep up with the cleanliness, wiping the machines, but it's still just personal kind of awareness and personal kind of decision making as to whether you feel safe or not.
Okay. All right. Well, I think we will wrap it up for today. I will
One second. I think there's Laura Wallace has her hand raised. I'm not sure if you saw that,
Oh,
but
okay. I'm sorry.
no, I just want to make sure she gets a chance to ask her question.
No problem, and I don't want to be a hog, but I wanted to know if air exchange is the thing that I'm concerned about, not surface, or you know, I wear masks, or so I'm not frightened of touch or sort of immediate risk by having someone walk past me, but it's the fresh air exchange because so many buildings are sealed like a ziploc. Thank you.
The ACAC gyms have, I can't remember, do you remember what they're called? They have the systems that clean out the airborne particles and whatnot. There's a specific name to the system, but it's I think it's been approved by the CDC to be effective with removing airborne pathogens. So all of the ACAC gyms have that within the gyms, and I think they have multiple ones in the larger surface areas.
And yeah, Katie, yes. So I will send the recording of the presentation to all of you who have attended today. I know you had to kind of register as you came in, and we do that for that purpose. So yeah, so we will certainly make sure that everybody gets that. Okay. All right. Okay, well, I think we are good to go. And again, you know, feel free to email, you know, you can email me. I will send out Ashleigh and email. If Dr. Roach is willing, I'll talk to her about that and see if we can't get her information, or Abigail, someone out to you guys. So thank you guys so much for joining us today.
Thank you, Dr. Roach.
Yes.
Thank you
So much.
Have a great day, everyone.
You